Okay, guys, so this lecture is about lymphatic system. Lymphatic system is a network of delicate tubes throughout the body. It drains fluid, which we call lymph, that has leaked from the blood vessels into the tissues, and it empties it back into the bloodstream via the lymph nodes. The main roles of the lymphatic system include managing the fluid levels in the body. Now, question arises, what is lymph? Lymph is a tissue fluid, which is interstitial fluid that enters the lymphatic vessels and carried back to the bloodstream in the subclavian veins. So as we know that we have a circulatory system, the heart is pumping the oxygenated blood, which is coming after purification or after oxygenation from the lungs and to the various parts of the body. And veins, they are collecting the deoxygenated blood and carrying it back to the heart. Heart is sending it to the lungs, from where after oxygenation it is coming back, and the cycle continues. Well, there is an other circulatory system which we call the lymphatic system. It is comprised of lymph duct, lymph trunk, lymph nodes, then the lymphatic collecting vessels, etc., etc. And finally, they would be draining into the bloodstream. So lymphatic system is basically a drainage system which is accessory to the venous system. And the larger particles that escape into the tissue fluid, which can only be removed via lymphatic system, they will be taken into that system. Let's see the functions of the lymphatic system. It reabsorbs excess interstitial fluid and returns it to the venous circulation, maintains blood volume levels, prevent interstitial fluid levels from rising out of control. It also transports dietary lipids transported through the lacteals, drain into the larger lymphatic vessels. Eventually, that is going to be drained into the bloodstream. Lymphocyte development and the immune response, that is also one of the functions of the lymphatic system. If we look at the components of the lymphatic system, so lymph, that fluid which I told you, or that liquid which I told you, which is being taken away, or which has been absorbed by the lymphatics. Then the lymphatic vessels. These are lymphatic capillaries, lymphatic vessels, lymphatic trunks, lymphatic ducts. Lymphatic organs are thymus, lymph nodes, spleen, tonsils, and then there are lymphatic cells. Lymphatic vessels. These are lymphatic capillaries, lymphatic collecting vessels, lymphatic trunks, lymphatic ducts. So what happens actually? Lymphatic capillary, it is carrying the, after absorbing the lymph from various parts of the body, then it is draining into the lymphatic vessel. Lymphatic vessel will be carrying the lymph into the lymph node, and after the lymph node, the lymph will be drained into the lymphatic vessel, which will take it to the lymphatic trunk and then into the collecting duct. The collecting duct finally drains into the subclavian vein. Lymphatic capillaries. If we look at the features of the structure of the lymphatic capillaries, they have blind end. There is a single layer of overlapping endothelial cells. They are more permeable than that of the blood capillary. They are absent from the avascular structures. Like those structures which are avascular, lymphatic capillaries are not present over there as well. Brain, spinal cord, they don't have lymphatic vessels or lymphatic capillaries, and splenic pulp as well as bone marrow. Lacteals. The small intestine contains special types of lymphatic capillaries, which we call lacteals. Lacteals, they pick up not only interstitial fluid, but also they carry dietary lipids and lipid-soluble vitamins. The lymph of this area has a milky color due to the lipid, and we call it chyle. Lymphatic vessels. Features of this structure of the lymphatic vessels, three-layered wall they have, but thinner than the veins. More numerous walls as compared to veins. Though some of the veins, they have valves, but these lymphatic vessels, they have valves more in number. Interposed by the lymph nodes at intervals, and they are arranged in superficial and deep sets. Lymphatic trunks. Let's see what different lymphatic trunks are there. Firstly, right and left jugular trunks. Then right and left subclavian trunks. And right and left bronchomediastinal trunks. Then right and left lumbar trunks. These are the lumbar trunks. And then the final one is the intestinal trunk. This is the intestinal trunk. Right lymphatic duct. We are talking now about the lymphatic ducts. It is formed by the union of right jugular, subclavian, and the bronchomediastinal trunks. It ends by entering the right venous angle here. We can have a closer look over here. Then comes the thoracic duct. It begins in front of vertebra L1 as a dilated sac, the cisterna chyli, formed by left and right lumbar trunks and the intestinal trunk here. It enters the thoracic cavity and then it ascends. It travels upward, veering to the left at the level of vertebra thoracic 5, T5, like this, from L1 all the way up to T1. T5, sorry, L1 all the way up to T5. Well, we are talking about the thoracic duct. At the root of the neck, it turns laterally, like this, arches forwards and descends to enter the left venous angle here. Before termination, it receives the left jugular, subclavian, and bronchomediastinal trunks. Well, it is not that the body is divided half and half for the drainage of lymphatic. The drainage of lymphatic is very interesting. Like this dark green color on the right-hand side, that is going to be drained in one way, and rest of the light green area, that is going to be drained in another way. So let's see how. This area is drained by the right lymphatic duct, and this is by the thoracic duct, this light green. Right lymphatic duct, this one, it receives lymph from the right half of the head, neck, thorax, and the right upper limb, right lung, right side of the heart, and right surface of liver. Whereas thoracic duct, it drains lymph from lower limbs, pelvic cavity, abdominal cavity, left side of thorax, and left side of the head, neck, and left upper limb. Lymphatic cells. They are also called lymphoid cells. They are located in both the lymphatic system and the cardiovascular system. They work together to elicit an immune response. Now let's see what are the different types of lymphatic cells. Macrophages. This is a type of white blood cells that surrounds and kills microorganisms, removes the dead cells, and stimulates the action of other immune system cells. Then comes the endothelial cells. Well, lymphatic endothelial cells, they form the structure of the lymphatic vessels and sinuses of the lymph nodes, positioning them to be key players in many different aspects of the immune response. Following an inflammatory stimulus, these lymphatic endothelial cells, which are also known as LECs, they produce chemokines that recruit immune cells to the lymph nodes. Then comes the dendritic cells. A special type of immune cell that is found in tissues such as the skin and boosts immune response for showing antigens on its surface to other cells of the immune system. A dendritic cell is a type of phagocyte and a type of antigen presenting cell, which is also known as APC, antigen presenting cell. Then comes lymphocytes, a type of immune cell that is made in the or produced in the bone marrow and is found in the blood and in lymph tissue. They are of two types, the B lymphocytes and the T lymphocytes. B lymphocytes, they make antibodies, and T lymphocytes, they help kill tumor cells and help control the immune responses. Then comes the lymphatic organs. There are two major types of lymphatic organs, the primary organs and the secondary organs. Red bone marrow and thymus, these are the primary organs, and lymph nodes, lymph nodules, and spleen, these are the secondary lymphatic organs. Then comes the lymph nodes. This is a typical lymph node. Here we can see its hilus. We can see it is receiving through the afferent lymphatic vessels the lymph from other parts or from other nodes, and then afferent lymphatic vessels, they will be draining the lymph into either some lymphatic vessel or into another lymph node. So they are small, round, or oval. They are located along the pathways of lymph vessels. Length is between 1 to 25 millimeters. Typically, they are found in clusters, but they can be found just one at one place as well. They receive lymph from many body regions. Lymph nodes are also found individually, as I told you, throughout the body tissues. Well, features of the structure of the lymph nodes, they are bean shaped with afferent vessels incoming, entering at the periphery, and the efferent leaving out. They will be taking the lymph out of it into the, like they are emerging from the hilus. As I told you, they could be draining into some lymph vessel, or they could be draining into another, or taking the these efferent vessels, they would be taking the lymph to some other lymph node as well. So they are arranged in groups along the blood vessels or the flexural side of the joint, divided into superficial and deep groups. Regional lymph. That is the lymph node where the lymph of the organ or part of the body drains at first. And that is why when we suspect some problem, or when we see that a regional lymph node is inflamed, then we suspect that in that region there is some pathological thing is going on. It could be an inflammation, it could be an infection, or it could be some serious thing like maybe a malignancy. Spleen. Well, it is located at the left epigastric region between 9th and 11th rib in the line of 10th rib. It is the largest lymphatic organ in the body. Usually question comes that which is the largest lymphatic organ in the body? It is the spleen. It can vary considerably in size and weight, and its function is it acts as a filter of blood as part of the immune system. Old red blood cells are recycled in the spleen, and platelets and white blood cells are stored there. The spleen also helps fight certain kinds of bacteria that cause pneumonia and meningitis. Then comes thymus. Well, if we look at the features of this thymus, it consists of two elongated lobes. It is a large organ in the fetus, but as the age advances, then the size starts regressing. Well, it occupies the thoracic cavity behind the sternum here, and it secretes lymphopoietin. Lymphatic nodules. Well, these are the oval clusters of lymphatic cells with some extracellular matrix that are not surrounded by a connective tissue capsule. Well, they filter and attack the antigens. In some areas of the body, many lymphatic nodules, they group together to form the larger structures like mucosa-associated lymphatic tissue, which we also call MALT or tonsils. They are very prominent in the mucosa of the small intestine, primarily in the ileum. Then they are, which we call the Pear patches, they are also present in the appendix. MALT or mucosa-associated lymphatic tissue, the Pierce patches, tonsils, and the appendix, they are all present in the digestive tract. Then lymphoid nodules in the walls of the bronchi are also present in, which we say, in the respiratory tract. MALT protects the digestive and respiratory systems from the foreign matter. Then comes tonsils. Clusters of lymphatic cells and extracellular matrix not completely surrounded by a connective tissue capsule. They consist of multiple germinal centers and crypts. Several groups of tonsils form a protective ring around the pharynx, pharyngeal tonsils or adenoids in nasopharynx, palatine tonsils in oral cavity, lingual tonsils along posterior 1/3 of the tongue. Valder's ring. Valder's tonsillar ring consisting of an unpaired pharyngeal tonsil in the roof of the pharynx, then paired palatine tonsils, and then various scattered lingual tonsils in the root of the tongue. We are discussing MALT, mucosa-associated lymphoid tissues. Lymphatic drainage of head and neck. Now we are going to discuss that topic. The vertical chain consists of superior and inferior groups of nodes related to the carotid sheath. All lymph vessels of the head and neck drain into the deep cervical nodes, either directly from the tissues or indirectly via nodes in outlying groups. Lymph is returned to the systemic venous circulation via either the right lymphatic duct or the thoracic duct. Here we can see various lymph nodes of the head and neck region and how they are clustered, and then that's how we group them and name those groups. Classification. It is taken from the textbook of head and neck anatomy, 4th edition, published in 2010. So name of the nodes, location, their afferent, from where they are getting the lymph, and where they are being drained afferent. So occipital, they are 2 to 4 in number, and they are located at the superior nuchal line between the sternocleidomastoid and the trapezius muscle. They are receiving the lymph from occipital part of the scalp, and then they are being drained into the superficial cervical lymph nodes and the accessory lymph nodes. Mastoid lymph nodes, they are 1 to 3 in number. They are located at superficial to the sternocleidomastoid insertion, and they are receiving lymph from the posterior parietal scalp, skin of the ear, posterior external acoustic meatus, and they are being drained into the superior deep cervical nodes and accessory lymph nodes. Then comes preauricular. As the name suggests, preauricular, they are 2 to 3 in number. Well, they are located anterior to the ear over parotid fascia, as I told you, as the name suggests. They are receiving lymph that they are draining the area supplied by the superficial temporal artery, anterior parietal scalp, and the anterior surface of ear. And then they are being drained into the superior deep cervical lymph nodes. Here we can see the parotid and preauricular lymphatics. So their location, they are embedded in parotid or just below the parotid gland. This is the area, the one in the blue, and then they drain the root of the nose, eyelids, then frontotemporal region. They also drain the external auditory meatus, floor and superior of the nasal cavity, as well as they drain the parotid gland. Well, they are being drained to superior deep cervical nodes. Again, these are the superior deep cervical nodes along the sternocleidomastoid muscle. Now, let's see parotid. They are up to 10 or more. and they are located about parotid gland and under parotid fascia deep to parotid gland. They are receiving lymphatics from the external acoustic meatus, skin of frontal and temporal regions, eyelids, tympanic cavity, cheek, nose, as well as posterior palate. And they are being drained into the superior deep cervical lymph nodes. Then comes facial. Facial are superficial and deep. Superficial, they are up to 12 in number, and they are maxillary, buccal, and mandibular. Well, they are distributed along the course of facial artery and facial vein. And they are draining skin and mucous membranes of eyelids, nose, and cheek, and they are being drained into the submandibular nodes. The deep ones, they are distributed along the course of maxillary artery, lateral to lateral pterygoid muscle, and they are draining temporal and infratemporal fossa, nasal pharynx, and they are being drained into the superior deep cervical lymph nodes. Cervical lymph nodes, superficial and deep. The superficial one, they are located at the anterior jugular vein between superficial cervical fascia and infrahyoid fascia. They are draining skin, muscles, and viscera of the infrahyoid region of the neck, and then they are being drained to superior deep cervical lymph nodes. The deep ones, they are situated between viscera of the neck and investing layer of deep cervical fascia. They are receiving lymph from adjoining parts of the trachea, larynx, and thyroid gland, and they are being drained into the superior deep cervical lymph nodes. Anterior cervical superficial, submental lymph nodes. They are 2 to 3 in number, and they are located, as the name suggests, in the submental triangle. They are draining chin, medial part of the lower lip, lower incisor teeth, and gingiva, tip of the tongue, and cheeks. Mostly questions are being asked about these lymph nodes. Of course, about submandibular as well, but submental, definitely questions come on this in different exams. So submandibular lymph node, they are being drained to submandibular lymph node, to jugulo-omohyoid lymph node, and superior deep cervical lymph nodes. Here we can see the submental lymphatics. They are draining midline of the jaw below chin between the anterior valleys of the digastric. Well, they are located over there. They are draining central portion of the lower lip, tip of the tongue, anterior portion of the floor of the mouth. And questions, they come on these structures where they are being drained into the submental lymphatics. Well, they drain to the submandibular lymph nodes and deep cervical lymph nodes. Tip of the tongue also being drained there. Remember these things. Submandibular lymph nodes, they are 3 to 6 in number, and they are situated in the submandibular triangle adjacent to the submandibular gland. Again, the name is quite suggestive where they are located, and they are draining facial nodes, chin, lateral upper and lower lip, submental nodes, cheeks and nose, anterior nasal cavity, maxillary and mandibular teeth and gingiva, oral palate, lateral parts of the anterior 2/3 of the tongue. And they are being drained into the superior deep cervical lymph nodes and jugulo-omohyoid lymph nodes. Then comes superficial cervical lymph nodes. They are 1 to 2 in number, and they are situated along the external jugular vein superficial to the sternocleidomastoid muscle. They are draining lower part of the ear and parotid region, and they are being drained into the superior deep cervical lymph nodes. Here we can see submandibular or submaxillary lymphatics. These are submandibular or submaxillary lymphatics. Location below mid portion and body of the mandible about the submandibular gland. And they are draining side of the nose, we can see, then lateral portion of the lower lip, lateral portion of the lower lip, then mid portion of the eyelids, buccal mucosa and cheek, we can see that, buccal mucosa and cheek, then anterolateral margins of the tongue, anterolateral margins of the tongue, and gingivae. Yes, mid portion of the eyelids as well. Well, they drain to deep cervical nodes. We can see that. Superficial cervical lymphatics. Their location about the external jugular vein, anterior to this is the sternocleidomastoid. So they are situated anterior to the sternocleidomastoid muscle. They drain external ear and parotid gland, external ear and parotid gland. And then they are being drained into the deep cervical lymph nodes, which are lying posterior to the sternocleidomastoid muscle. Well, deep cervical lymph nodes, superior deep cervical, surrounding internal jugular vein, deep to sternocleidomastoid and superior to omohyoid muscle. They are situated there. And they are draining occipital nodes, mastoid nodes, preauricular nodes, parotid nodes, submandibular nodes, superficial cervical nodes, and retropharyngeal nodes. They are being drained into the inferior deep cervical nodes or separate channel to jugulo-subclavian junction. Then comes the jugulo-digastric. As the name suggests, they are situated at junction of the internal jugular vein and posterior digastric muscle. Posterior belly of the digastric muscle. Well, they are draining palatine and lingual tonsils, posterior palate, lateral portions of the anterior two-thirds of the tongue. And they are being drained to the inferior deep cervical lymph nodes. Deep superior cervical lymphatics. Location, course of the carotid artery and the internal jugular vessels behind the sternocleidomastoid muscle, this one. They drain back of the neck, then occipital region of the scalp, portion of the external ear, post and central portions, tongue, palate, like posterior and the central portions of the tongue, palate, nasopharynx, nose, larynx, and upper esophagus. We can see all these arrows which are coming here. So it is draining that. And then they themselves drain to the jugular trunk. Jugulo-omohyoid. They are situated above the junction of the internal jugular vein and omohyoid muscle, and they are draining posterior one-third of the tongue, submandibular nodes, and submental nodes, and they are being drained into the inferior deep cervical lymph nodes. Then comes the inferior deep cervical lymph nodes, where they are situated along the internal jugular vein below omohyoid muscle deep to the sternocleidomastoid muscle. And they are draining transverse cervical nodes, then anterior cervical nodes, superior deep cervical nodes, and they themselves are being drained into the jugular trunk. Then comes the retropharyngeal lymph nodes. They are 1 to 3 in number, and as the name suggests, where they are present at the retropharyngeal space. Well, they are draining posterior nasal cavity, paranasal sinuses, hard and soft palate, nasopharynx, oropharynx, and the auditory tube. I'm sorry for the spelling. It is auditory tube. Instead of N, it should be U. And then they are being drained into the superior deep cervical nodes. Here we can see deep inferior cervical lymphatics, location, inferior portion of course of the carotid artery and internal jugular vessels here. And they are draining back of the neck, lower portion of the occipital scalp, and the superior anterior chest wall. They drain to the deep jugular trunk. Then comes accessory. Again, name is suggestive. They are 2 to 6 in number. They are along the accessory nerve in the posterior triangle, and they are draining occipital nodes, mastoid nodes, lateral neck, and shoulder, and they are being drained into the transverse cervical nodes. Then comes transverse cervical lymph nodes. They are 1 to 10 in number, and they are situated along transverse cervical blood vessels at the level of clavicle. They are draining accessory nodes, apical axillary nodes, lateral neck, and anterior thoracic wall. They are being drained into the jugular trunk or directly into the thoracic duct or right lymphatic duct or independently into the junction of internal jugular vein and subclavian vein. So here we can see the whole network of these lymph nodes and the lymphatic vessels which are present in the head and neck region. Questions also come in a different way, like they can ask you about the lymph drainage of the external nose. So over here, I have just made a little bit more precise and concise for you in this way that you will get the answers in this manner. So lymph drainage of the external nose. Lymph drainage of the external nose is primarily to the submandibular group of the nodes. Although lymph from the root of the nose, it can drain to the superficial parotid nodes as well. Well, we are discussing the lymphatic drainage of the nasal cavity. Lymph vessels from the anterior region of the nasal cavity pass superficially to join those draining the external nasal skin and end in the submandibular nodes. The rest of the nasal cavity, paranasal sinuses, nasopharynx, and pharyngeal end of the pharyngotympanic tube all drain to the upper deep cervical nodes, either directly or through the retropharyngeal nodes. The posterior nasal floor probably drains to the parotid nodes. Lymphatic drainage of the tongue, it is very, very important. The lymphatic drainage of the tongue can be divided into three main regions: marginal, central, and dorsal. The anterior region of the tongue drains into the marginal and central vessels, and the posterior part of the tongue behind the valate papillae drains into the dorsal lymph vessels. The more central regions, they drain bilaterally into the submental and submandibular nodes. Here we can see, it's a very nice diagram. These at the posterior tongue to superior deep cervical lymph nodes directly. This is the tonsillar form. And to this one to inferior deep cervical lymph nodes. Then this from the lateral border to submandibular lymph nodes. And tip of the tongue to submental lymph node. Here we can see those lymph nodes in the neck where they are present. Lymphatic drainage of the teeth. The lymph vessels from the teeth usually run directly into the ipsilateral, means on the same side, submandibular lymph nodes. Ipsilateral, submandibular lymph nodes. Lymph from the mandibular incisors, however, drain into the submental lymph nodes, and usually question comes on that, about the lymphatic drainage of the mandibular incisors. Occasionally, lymph from the molar may pass directly into the jugulo-digastric group of the lymph nodes. Now, let's see some applied aspects. When a lymph node is under challenge from a foreign antigen, it may become swollen and painful to the touch, a condition which we call lymphadenitis. Commonly palpated and accessible lymph nodes are the cervical, axillary, and inguinal. Lymph nodes are common sites of metastatic cancer because cancer cells from almost any organ can break loose, enter the lymphatic capillaries, and lodge into the nodes. Lymphadenopathy is a collective term for all lymph node diseases. Block dissection of the neck. Treatment for malignant disease is the removal of the lymph nodes of the anterior and posterior triangles of the neck and their associated lymph channels, together with those structures which must be excised in order to make this lymphatic ablation possible. Tuberculosis of the neck, or tuberculous disease of the neck, usually involves the upper part of the deep cervical chain from tonsillar infection. These infected nodes may adhere very firmly to the internal jugular vein, which may be wounded in the course if you are going to excise these lymph nodes. So the internal jugular vein may get wounded. Spread of supra and subglottic tumors. The upper deep cervical lymph nodes act as pathways of spread for malignant tumors of the supraglottic larynx. Up to 40% of these tumors will have undergone such a spread at the time of clinical presentation. The glottis is very poorly endowed with lymphatic vessels. 95% of the malignant tumors, they are confined to the glottis. They will present with a change in voice or airway obstruction, but will not show signs of any spread to the adjacent lymph nodes at the time of presentation. Tumors of the subglottic larynx will often spread to the paratracheal lymph node chain prior to clinical presentation. However, the presenting symptoms may be voice change and airway obstruction rather than a mass in the neck. because the paratracheal lymph nodes, they occupy a deep-seated position in the root of the neck, and so their enlargement, it may remain occult. Now let's see cervical lymph nodes, the metastasis to them by the primary cancer site. So lymph node site, submental and submandibular, both are considered as level 1 lymph nodes. Primary cancer site will be from lip, oral cavity, skin, salivary gland, etc., etc. Upper jugular nodes, level 2, and they would be getting probably the lymph from the areas when the oral cavity, oropharynx, nasopharynx, larynx, and salivary gland, they would be having primary cancer. Mid-jugular nodes, they are level 3, and primary cancer site would be present in oral cavity, oropharynx, hypopharynx, larynx, and thyroid. Lower jugular nodes, level 4, their primary cancer site would be oropharynx, hypopharynx, larynx, cervical, esophagus, and thyroid. Then comes accessory nerve nodes. They are at level 5. And primary cancer site would be nasopharynx and scalp. Supraclavicular nodes, they are level 5, and primary cancer site would be either breast or lung or GIT. Then suboccipital nodes, the primary cancer site would be skin, and parotid nodes, the primary cancer site would be skin or parotid gland. Lymphadenopathy. Lymphadenopathy is basically enlargement of the lymph nodes. It may be an incidental finding in patients being examined for various reasons, or it may be a presenting sign or symptom of the patient's illness. Soft, flat submandibular nodes less than 1 centimeter are often palpable in healthy children and young adults. Healthy adults may have palpable inguinal nodes of up to 2 centimeters, which are considered normal. Generalized lymphadenopathy. It has been defined as involvement of 3 or more non-contiguous lymph node areas. Generalized lymphadenopathy is frequently associated with non-malignant disorders like infectious mononucleosis, which is caused by Epstein-Barr virus or by the cytomegalovirus. Then toxoplasmosis, AIDS and other viral infections, systemic lupus erythematosus, and mixed connective tissue diseases. Well, acute and chronic lymphocytic leukemias and malignant lymphomas also produce generalized adenopathy among the adults. Localized or regional lymphadenopathy. It implies involvement of a single anatomic area. The site of localized or regional adenopathy may provide a useful clue about the cause, because at least we would be knowing which areas those lymph nodes would be draining. So we will focus on those areas to find out the primary cause. For example, occipital adenopathy often reflects an infection of the scalp, and preauricular adenopathy, it accompanies conjunctival infections and the cat scratch disease. Diseases associated with lymphadenopathy: viral, infectious mononucleosis syndromes, Epstein-Barr virus or cytomegalovirus, then infectious hepatitis, herpes simplex, herpesvirus type 6, varicella zoster virus, rubella, measles, then adenovirus, HIV, epidemic, keratoconjunctivitis, vaccinia, and herpesvirus type 8. Then bacterial problems: streptococci, staphylococci, cat scratch disease, brucellosis, then tularemia, plague, then cancroid, melioidosis, then comes glanders, tuberculosis, atypical mycobacterial infection, primary and secondary syphilis, diphtheria, and leprosy. Then the fungal problems: histoplasmosis or coccidioidomycosis or paracoccidioidomycosis. Then comes chlamydal problems: lymphogranuloma, venereum, and trachoma. Then parasitic problems: toxoplasmosis, leishmaniasis, trypanosomiasis, and filariasis. Then rickettsy, scrub typhus, rickettsial pox, or Q fever. Immunological diseases like rheumatoid arthritis, juvenile rheumatoid arthritis, mixed connective tissue disease, systemic lupus erythematosus, dermatomyositis, then Sjogren syndrome, serum sickness, drug hypersensitivity, diphenyl hydantoin drug, hydralazine, then allopurinol, primidone, gold, and carbamazepine. So all these drugs, their hypersensitivity can also cause the lymphadenitis. Then angioimmunoblastic lymphadenopathy, primary biliary cirrhosis, graft host reaction, silicon associated problem, autoimmune lymphoproliferative syndrome. Malignant diseases like hematological Hodgkin's disease, non-Hodgkin's lymphomas, acute or chronic lymphocytic leukemia, hairy cell leukemia, malignant histiocytosis, amyloidosis, etc., and the metastatic tumors from numerous primary sites. Then lipid storage diseases, Gaucher's and Niemann-Pick, Fabry, and Tangier diseases. Endocrine problems like hyperthyroidism, adrenal insufficiency, and thyroiditis, they can also lead to the lymphadenopathy. Other problems like Castleman's disease, giant lymph node hyperplasia, sarcoidosis, dermatopathic lymphadenitis, lymphomatoid granulomatosis, histiocytic necrotizing lymphadenitis, then sinus histiocytosis with massive lymphadenopathy, that is Rosai-Dorfman disease, then the mucocutaneous lymph node syndrome, which is also known as Kawasaki disease, histiocytosis X, familial Mediterranean fever, severe hypertriglyceridemia, vascular transformation of sinuses, inflammatory pseudomotor of lymph node, and then congestive cardiac failure, etc., etc. Clinical assessment. The physician will be able to diagnose the cause of lymphadenopathy by a thorough medical history, detailed physical examination, selected laboratory tests, and an excisional lymph node biopsy if that is required. Not in every case we will be going for the lymph node biopsy. Medical history, what it's going to reveal. It should reveal the setting in which lymphadenopathy is occurring. Symptoms such as sore throat, cough, fever, night sweats, fatigue, weight loss, or pain in the nodes should be sought. The patient's age, their sex, occupation, exposure to pets, sexual behavior, and use of drugs such as diphenylhydantoin are other important historic points. We are discussing medical history. For example, children and young adults usually have benign, that is non-malignant disorders that account for the observed lymphadenopathy such as viral or bacterial upper respiratory infections, infectious mononucleosis, toxoplasmosis, and in some countries, tuberculosis as well. In contrast, after age 50, the incidence of malignant disorders increases and that of benign disorders decreases. Physical examination. It can provide useful clues such as the extent of lymphadenopathy, localized or generalized, size of the nodes, texture, presence or absence of nodal tenderness, signs of inflammation over the node, skin lesions, and may be or may not be splenomegaly present. Size of the lymph nodes. Nodes which are less than 1 centimeter square in area are almost always secondary to benign non-specific reactive causes. In one retrospective analysis of younger patients 9 to 25 years who had a lymph node biopsy, a maximum diameter of less than 2 centimeters served as one discriminant for predicting that the biopsy would reveal malignant or granulomatous disease. Patients with nodes that 1 centimeter square should be observed after excluding infectious mononucleosis and or toxoplasmosis unless there are symptoms and signs of an underlying systemic illness. Texture of the lymph nodes is also important. The texture of lymph nodes may be described as soft, firm, rubbery, hard, discrete, or matted. It may be tender or it could be non-tender as well. So again, it could be movable or it could be fixed. Tenderness is found when the capsule is stretched during rapid enlargement, usually secondary to an inflammatory process. Some malignant diseases such as acute leukemia may produce rapid enlargement and nodes would be painful. Well, nodes involved by lymphoma, they tend to be large, discrete, symmetric, rubbery, and firm, mobile, and non-tender. Well, here we can see differential diagnosis of the cervical lymphadenopathy based on the palpatory finding. So upon palpation, if it is matted, it would be tuberculosis, cystic and soft, it would be due to cold abscess, rubbery, Hodgkin's lymphoma, firm due to syphilis, stony heart due to some malignancy or carcinoma. Clinical assessment. Nodes containing metastatic cancer are often hard, non-tender, and non-movable because of fixation to surrounding tissues. The coexistence of splenomegaly in the patient with lymphadenopathy implies a systemic illness which could be infectious mononucleosis, maybe a lymphoma, acute or chronic leukemia, then SLE, sarcoidosis, toxoplasmosis, cat scratch fever, or other less common hematological disorders. Palpation of lymph nodes, we are discussing. Lymph node and chain palpation starts with the parotid and preauricular area, which may also be palpated by manually. Palpating with light finger pressure against underlying firm tissues, bone or muscle, or bimanually where it is appropriate. The head and neck lymph examination continues down the mandible to the submandibular region, where bilateral palpation proceeds forward to the submental nodes just under the chin. With the patient seated upright, head tipped slightly forward, the cervical lymphatic chains are palpated against the sternocleidomastoid muscle. Superficial cervical lymph nodes are found along the anterior border, and deep superior and inferior chains found along the posterior border. Here we can see that's how we check the submandibular lymphatics, and this is bilateral palpation for the submental lymphatics. That's how the patient should be in a relaxed upright position to palpate along the sternocleidomastoid muscle. The superficial cervical lymphatics, they would be found anteriorly to this muscle. Then posterior to this muscle, deep cervical lymphatics, they will be palpated, and the deep inferior cervical lymphatics may also be palpated against the lower border of the lower posterior border of the sternocleidomastoid muscle. Now let's discuss certain applied anatomy to the lymphatic system. Lymphangitis. It is the inflammation of the lymph vessels. Commonest cause bacteria, which is known as Streptococcus pyogenes, the most common one. Lymph vessels, they appear as red streaks throughout the skin. Filariasis. Filariasis is a disease where mosquitoes, they get the larvae after biting an infected person and then transmitting it to a healthy person. And then those larvae, they mate, then they lay eggs, they multiply in number, and they destroy the lymphatic system of that person, which may lead to elephantiasis. And again, they will be a source of infection. When the mosquito are going to bite them, they will take larvae from there, and then they will spread to the healthy people again. This is how elephantiasis may occur. One of the major reasons of disability after leprosy. Lymphedema. It occurs due to accumulation of lymphatic fluid in the interstitial tissue, sometimes can be appreciated after wearing tight clothing or jewelry on affected limb. Lymphadenopathy. It means a disease of the lymph nodes. Lymph nodes become swollen, enlarged, and may be painful to touch. We have discussed it in detail that regional lymphadenopathy and generalized lymphadenopathy are all the reasons why it could occur. Lymphomas. Cancers originating either from the lymphocytes in the lymph nodes or the lymphatic tissue in organs. Risk factors would be HIV, hepatitis, and Epstein-Barr virus infections. Tonsillitis. Infections of the pharyngeal tonsils. Tonsils would appear swollen, fever and pain during swallowing usually present. Treatment would be surgical removal of tonsils or tonsillectomy. Splenomegaly. Enlarged spleen is splenomegaly. And splenomegaly is an enlargement of the spleen because of its wide variety of functions. The spleen may be affected by many conditions involving the blood or lymph system and by infection, malignancies, liver disease, and maybe presence of parasites. So over here, we are done with our this very important and long lecture. Hopefully you would have enjoyed it. Thank you very much.